Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 447 of our pharmacotherapy series, which majors in colorectal cancer. The first question in this video applies to patient BSR from part 446 of this pharmacotherapy series. BSR is scheduled to receive a modified FOLFOX6, abbreviated as mFOLFOX6, regimen in the adjuvant setting. My next questions to you read: what potential adverse effects should BSR be made aware of before receiving this regimen? Are any dose-limiting side effects associated with this therapy? Are there any preventive measures that can be taken to limit the severity of these adverse effects? The goal of therapy in this setting is a cure. Therefore, clinicians typically try to remain aggressive and limit chemotherapy dose reductions or delays while trying to maintain an acceptable toxicity profile. There are a number of chemotherapy-related toxicities that may occur during adjuvant therapy or after its completion. Toxicities related to fluoropyrimidines include hand-foot syndrome, abbreviated as HFS, also called palmar-plantar erythrodysesthesia, mucositis, diarrhea, hematologic toxicities, neutropenia, photosensitivity, and rarely, cardiac toxicity, vasospastic angina. Hand-foot syndrome is managed primarily with supportive care measures, such as the application of topical moisturizers in addition to temporary withdrawal of fluorouracil-based therapy to allow time to heal. Once healed or decreased in its severity, fluorouracil-based therapy is often resumed at a reduced dose. The frequency and severity of hand-foot syndrome is increased with carpacetarbine versus fluorouracil. Severe neutropenia is typically managed with chemotherapy dose reductions or delays, and in some cases clinicians may use the administration of granulocyte colony stimulating factors, such as filgrastim or pegfilgrastim, to prevent febrile neutropenia while maintaining dose intensity. The incidence of neutropenia is higher with bolus fluorouracil than with infusional fluorouracil or with carpacetarbine. Severe mucositis is uncommon and is mainly associated with bolus fluorouracil. Moderate to mild symptoms can also occur. However, with carpacetarbine or infusional fluorouracil, and these can be managed with supportive care measures, such as mild narcotic pain medications or mouthwashes that contain a local anesthetic such as lidocaine. Strategies for preventing this complication are also important and include stressing the importance of good oral hygiene and avoidance of harsh substances, which may irritate the oral mucosa or inhibit saliva production, such as alcohol, alcohol-based mouthwashes or rinses, spicy foods, and anticholinergic medications. As is the case with many fluorinated pharmaceutical agents, fluorouracil and carp-acetarbine cause photosensitivity, which may result in mild to severe sunburns after sun exposure. Therefore, during fluoropyrimidine therapy, prolonged exposure to direct sunlight should be avoided and use of a sunblock of SPF 15 or higher during outdoor activities is recommended. Oxaliplatin is the newest member of the platinum family of antineoplastics, and it offers a different anti-tumor profile and resistance pattern than cisplatin or carboplatin. Of the three agents, oxaliplatin is highly active against colorectal tumors. Myelosuppression, primarily neutropenia and thrombocytopenia, and neurotoxicity are dose-limiting toxicities associated with its use. Oxaliplatin causes an acute, reversible neuropathy consisting of either paresthesias or dysesthesias and in some instances muscle spasms. One particular phenomenon that is distressing for patients is an involuntary laryngopharyngeal dysesthesia that can create the sensation of an inability to swallow or breathe. The acute phenomenon is reported to occur in greater than 90% of patients receiving oxaliplatin. Although our understanding of the event is limited, it is known to be triggered by direct contact with anything cold. This sensitivity to cold as well as the aforementioned reactions generally occur within minutes of receiving the infusion and can persist up to 7 days. Avoidance of cold objects, including the eating or drinking of cold foods and beverages, should be emphasized to patients after each dose of oxaliplatin. The use of gloves, socks, and scarves can also be recommended, especially in cold weather. Delayed, cumulative neurotoxicity may also occur, and it is potentially irreversible and occurs in a dose-dependent manner. It initially develops in the distal extremities and slowly progresses in a glove and stocking distribution pattern. It is typically characterized by a persistent sensation of numbness, tingling, or burning in the extremities. Hypersensitivity reactions have also been observed with oxaliplatin use with a reported incidence of 10% to 25%. And although the appearance of the reaction is arbitrary in that it can manifest with any dose, the median number of doses reported in those that have reacted is 7 to 9.26. Typically, the symptoms of hypersensitivity occur during the infusion, but delayed reactions are also possible. The severity of these allergic reactions can range from mild itching or flushing to anaphylaxis. After a reaction, mild cases are often managed through pre-medication with antihistamines or corticosteroids, e.g., diphenhydramine 50 mg IV or orally and either dexamethasone 20 mg or another corticosteroid 15 minutes before oxaliplatin IV, in addition to prolonging the infusion of oxaliplatin. More severe reactions generally warrant discontinuation of the drug. However, there are reports in which desensitization protocols have been used successfully, allowing for continued administration. Regardless of what is chosen, this strategy accompanies all subsequent doses of oxaliplatin. Liver toxicity has also been reported with oxaliplatin and is mainly characterized by sinusoidal injury. This can occur in as high as 51% of patients, although blatant liver failure with oxaliplatin is rare. Splenomegaly has been reported to correlate with sinusoidal liver injury, and this manifestation may also contribute to thrombocytopenia that may last long after oxaliplatin is discontinued. The primary role of chemotherapy in this setting is to reduce the risk of relapse and prolong disease-free survival by eradicating residual, undetectable disease. A total of 6 months of adjuvant therapy is considered the current standard of care after surgery with curative intent, 12 cycles of an every 2-week regimen like FOLFOX, or 8 cycles of an every 3-week strategy of carpe-cetabine with or without oxaliplatin. A large ongoing trial is currently evaluating the necessity of 6 months versus 3 months of therapy, but the results are pending. Because BSR will receive a combination of fluorouracil and oxaliplatin in the adjuvant setting, the toxicities of these agents should be discussed before initiation of therapy. The toxicity of fluorouracil will vary depending on its dose, route, and schedule of administration. At doses used in the treatment of colorectal cancer, bolus administration is associated with more severe neutropenia and mucositis, whereas continuous infusion administration is associated with more severe hand-foot syndrome. Fluorouracil is also associated with photosensitivity, so BSR should be counseled on the use of SPF 15 or greater sunscreen when outdoors because of the increased risk of sunburn. The main toxicities of oxaliplatin are thrombocytopenia, neuropathy, liver toxicity, and hypersensitivity reactions. To minimize the acute neuropathy after each dose, BSR should be counseled on the avoidance of cold objects, including the eating or drinking of cold foods and beverages. The use of gloves, socks, and scarves can also be recommended, especially in cold weather. BSR will also have labs drawn at regular intervals prior to administration of chemotherapy to ensure that his neutrophils and platelets are at a sufficient level to give chemotherapy and to monitor for changes in liver function that can occur with oxaliplatin. After 8 treatments of adjuvant therapy, BSR begins complaining of a constant numbness and tingling in his toes bilaterally. It is not interfering with his daily activities but is described as more of a nuisance. So my next question to you reads: which drug is most likely responsible for this and what course of action should be taken? As explained earlier, the severity of peripheral sensory neuropathy, abbreviated as PSN, can worsen with continued doses of oxaliplatin and is not readily reversible. Therefore, it is imperative that clinicians and patients work together to minimize its negative impact on various activities of daily living, such as being able to button a shirt, walking up or down stairs, or realizing whether one's foot is actually touching the brake pedal as the car approaches a red light. In the Hallmark clinical trial in the adjuvant setting, during the 6 months of therapy with oxaliplatin, fluorouracil, and leucovorin, 12.5% of patients reported grade 3 peripheral sensory neuropathy. However, this increased to 24.1% in the 18 months after treatment assessment, indicating that peripheral sensory neuropathy will continue to worsen even after cessation of oxaliplatin. It does appear that over time peripheral sensory neuropathy can improve off oxaliplatin, as at 4 years post-adjuvant treatment grade 1, 2, and 3 peripheral sensory neuropathy was observed in 11.9%, 2.8%, and 0.7%, respectively. In the metastatic setting, stop-and-go approach to limit exposure to oxaliplatin while retaining its anti-tumor effects and has been shown to be beneficial in delaying the development of peripheral sensory neuropathy without adversely affecting the outcomes of progression-free survival and overall survival. In this approach, oxaliplatin is withdrawn from therapy in patients with metastatic disease and is reinitiated when disease progression is noted. However, in the adjuvant setting where the goal is cure, the benefits of stopping therapy to decrease the risk of permanent peripheral sensory neuropathy must be weighed against the risk of recurrent disease. Newer trials in the adjuvant setting recommend holding oxaliplatin for a period of 4 weeks in the setting of persistent grade above 2 neuropathy, defined as persisting between treatments, and resuming at a dose reduction once peripheral sensory neuropathy resolves to grade 2 neuropathy that does not resolve within 4 weeks. Several small trials have been conducted to evaluate the effectiveness of certain pharmaceutical agents in the management of chemotherapy-induced peripheral neuropathy. These trials have focused on either the prevention or treatment of chemotherapy-induced peripheral neuropathy and as a whole have yielded disappointing results. To date, no agent is recommended as a chemoprotectant for the prevention of oxaliplatin-induced peripheral sensory neuropathy. Duloxetine, an antidepressant, has been studied in a randomized clinical trial and has shown to decrease specifically the pain component experienced by some patients with peripheral sensory neuropathy, including oxaliplatin-induced peripheral sensory neuropathy. In addition, tricyclic antidepressants such as nortriptyline and amitriptyline or an anticonvulsant such as gabapentin and pregabalin could be considered, as these agents have proven beneficial and are recommended as initial therapy in other neuropathic pain settings. It is important to note that when using adjunctive agents such as these to manage neuropathic pain, doses typically require upward titration after initiation. This strategy enables the clinician to find the dose that provides the greatest benefit. It is important to explain to the patient that these agents may take several weeks before a response is seen, and that the indication is for the pain associated with peripheral sensory neuropathy. These agents have not been shown to improve numbness or tingling. Symptom relief generally requires continued daily use of these agents on a scheduled basis. However, it is important to consider weaning them with time if neuropathic symptoms either improve or show no improvement despite optimal dosing. The timing of the symptoms that BSR is experiencing is indicative of the cumulative toxicity oxaliplatin exerts on peripheral sensory nerves. Because BSR has completed 8 of a planned 12 cycles of his adjuvant therapy and because his symptoms just started, the reaction would be graded as relatively mild in its severity at this point. He will likely benefit most from continued administration of oxaliplatin at a reduced dosage with diligent monitoring of his neuropathy. After completing his treatment, how often and for how long should BSR be monitored for recurrence of his disease? Because the majority of recurrences occur within the first 2 to 3 years after completion of adjuvant therapy, both the American Society of Clinical Oncology and the National Comprehensive Cancer Network, abbreviated as NCCN, have published guidelines that address the importance of patient follow-up and surveillance after definitive therapy for localized disease. Both organizations agree that patients treated definitively for localized disease should be monitored regularly for at least 5 years. Because most recurrences occur relatively soon, surveillance screening should be more frequent for the first 2 years and include a history and physical examination, and carcinoembryonic antigen level performed every 3 to 6 months for these first 2 years, then semi-annually thereafter for up to 5 years. In addition, future recommended imaging includes CT scan of the chest, abdomen, and pelvis performed at least annually for up to 5 years and colonoscopy within a year of surgical resection, or approximately 1 year from the original colonoscopy, and then repeated again in 3 years if no high-grade adenomas are identified. During the surveillance period, development of a concerning symptom on physical examination, an abnormality on a CT scan, or a rise in carcinoembryonic antigen level above the upper limit of normal, 3 nanograms per milliliter for non-smokers or 6 nanograms per milliliter for smokers, would necessitate further evaluation for disease recurrence. After the 5-year surveillance period, an increased risk for recurrent disease remains. Therefore, screening for colorectal cancer every 5 years in these patients will continue rather than the every 10-year screening recommended for the average risk population. BSR should be monitored regularly for at least 5 years. Should BSR remain disease-free throughout this 5-year surveillance period, he will be considered cured of his cancer. Because most recurrences occur relatively soon, his surveillance visits will be more frequent for the first 2 years with a history and physical examination and carcinoembryonic antigen level performed every 3 to 6 months, then semi-annually thereafter. He should also have a CT scan of his chest, abdomen, and pelvis performed at least annually for 3 years. Another colonoscopy should be performed within a year of his surgical resection or approximately 1 year from his original colonoscopy, and then repeated again in 3 years. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 448.